Okay. So it looks like we have 10 people signed on, and I think all of our major sites are here. So welcome everybody to Pharmacy Journal Club / Grade Rounds. It's sort of a hybrid today. So as you guys know, a lot of new inhaler devices are now available and have recently been added to the hospital formulary in New Brunswick. So Denise Campo, who's one of our DI/DUE pharmacists in Fredericton, has graciously agreed to speak to us today and give us an overview of what some of these new inhalers are and their place in therapy. So everybody at the major sites in Horizon, and I apologize for those in Vitalité that are joining us. I don't think we got to send samples out to you guys, but Fredericton, Moncton, Miramichi, St. John should all have some sample use devices that you guys can use as Denise goes through the presentation today. So I will hand it over to you, Denise.
Thanks, Heather. So as you mentioned, this is a journal club slot for presentation, but this is not your traditional journal club experience. It's essentially an overview of recent hospital formulary acquisitions and updates, and something of a mini update. So I do hope that the majority of the sites have access to some of the sample inhalers. My apologies to any of the sites that didn't get access. These are leftover demonstrators from the February Formulary Review Committee meeting at which the devices were reviewed. So not all sites got all of the available placebos. In particular, the Respimats were in short supply, the ones that had not already been assembled. So we'll do the best that we can with what we have, and hopefully we'll take away a few learnings. I do want to make some acknowledgements. So my second year Dalhousie University student Curtis Gallant created the bare bones of this presentation for a small 15-minute presentation in our department in May as part of his PEP 2081 rotation. So I did get his permission to adapt it and expand it. And Chantal Michaud, a DI/DUE pharmacist at the Moncton Hospital, collaborated with me in the presentation to Formulary Review Committee, and she was responsible for getting the placebo devices. So I do thank her for her efforts. I think she's at D&T today. I'm just wondering, are there sites on the line who can identify that they do not have the placebo inhalers?
St. Joe, we don't have any.
And I don't have any in Bathurst.
Okay, my apologies. I think you'll still get some information here. It's really nice to have the hands-on, though. I apologize you don't have that opportunity.
No problem.
The objectives for today are to review the range of drugs and devices that are available with a focus on the new format inhalers and a focus on COPD, recognizing that there is some overlap for indications in asthma with some of the inhalers. And if there's time, a quick run through of some of the old inhalers, some of which have new tricks. And review the use and counseling for the new devices, and maybe identifying some advantages and disadvantages of them, and also review challenges and opportunities. And recently the New Brunswick Drug Plan special authorization criteria have been updated, so I think there are some opportunities for improved delivery of care with that new innovation, so that's pretty recent. So the formulary looked at inhalers about 5 years ago and made recommendations for listing inhalers, at which time some of the commonly used formats were not listed on the formulary, including the Turbuhalers, and also at which time some therapeutic interchanges were devised and proposed. And since those decisions were made 5 years ago, there's been this influx of new devices and new requests for specific versions of devices. And when Formulary Review Committee was looking at these new inhalers one at a time, they kind of came to the conclusion that it didn't make much sense to look at them singly, that we needed to step back and look at all the inhalers broadly and make a new formulary, take a new approach to formulary listing. So FRC noted that the potential for interchanging the new products is low because of the devices are so unique. So if we were to continue with the theory of interchange, we would be contributing to patient misuse. And misuse leads to reduced efficacy and poor outcomes. So the FRC decided that we should stand back and take a look at the whole category. And I do want to acknowledge the work of Rochelle Dickey at the Moncton Hospital, who compiled much of the information that formed the basis of the presentation to Formulary Review Committee and recommendations to DNT. So thank you to Rochelle if she's available. This year, several new inhalers were added to formulary, including Ellipta, Breezhaler, Genuair, and Respimat. And subsequent to the March decisions, which introduced some of these new devices, in June, some of the older devices not previously listed were reviewed and added to formulary. So now we do have the Turbuhalers back in the formulary system. So there's been a lot of change, and the change continues. I just want to note there are some formats called RespiClick and Aerospheres, which are new devices that have been approved by Health Canada, maybe not yet marketed. So we could probably expect to see continued change in this category. And I would feel guilty if I didn't give passing mention to evidence for the use of the devices, but I've only cherry-picked some generalizations from the GOLD Guidelines Pocket Guide, just as a refresher. So we know that inhaled pharmacotherapy of COPD can reduce symptoms, reduce frequency and severity of exacerbations, reduce hospitalizations, improve health status, and exercise intolerance. But there's no clinical trial evidence that the currently available medications alter the long-term decline in lung function. More generalizations, LAMAs have shown to be better than LABAs in reducing exacerbations. Combinations of LABAs and LAMAs improve lung function greater than the individual monotherapies, although that improved lung function is not additive. You don't add up the benefits and get this, it's a lesser improvement than the sum of the parts. Caveat, most of the studies were performed in patients with low rates of exacerbations, so there's limits the conclusions that can be drawn. Also, there's conflicting results in patients with exacerbations in knowing whether LABA-ICS or LABA-LAMA combinations are preferable. So decisions really have to be made at the level of the individual patient. In patients with moderate to very severe COPD with exacerbations, adding an inhaled corticosteroid to the LABA is better than using either alone. But again, the caveat with the inhaled corticosteroids is that regular treatment can increase the risk of pneumonia, so patient selection is important. So really, when you're talking about patients in inhalers, you're looking at the intersection between the evidence and the patients. Successful clinical outcomes relies much on the choice of device as by the individual or combined drugs delivered, and clinical trial benefits don't necessarily translate into practice benefits because of poor patient execution and adherence. So some of the issues that come up every day pertain to the availability and the affordability of the devices for the desired drugs, what the patient prefers, what they've used before, what their physically or cognitively able to handle, how convenient is the device or how portable, and no less important is healthcare provider familiarity with the sea change that has occurred. It's a challenge to remain current with all elements. So in short, a perfect inhaler does not exist. Any given option could have limitations for an individual patient. So considering that patients with COPD typically have multiple comorbidities, reducing the amount of devices or interventions and making things as simple as possible are key considerations. So the new inhalers that have come to market over the years can be seen as a revolution in delivering COPD and asthma medications, but there's sort of like the old story is playing out, new formats, an old story. We know that up to 94% most patients use inhalers incorrectly at some point in the procedure of either setup, priming, delivery, post-use. And a substantial portion of COPD patients do make critical errors, and that's for the patients who are actually using the devices as prescribed by their healthcare provider. So there continues to be a huge gap in monitoring patient outcomes and use of devices and optimizing therapy of COPD. So now we'll sort of launch into playing with the devices for those sites that have them available. And I wanted to start with the Ellipta. That's for you.
That's for me.
So local areas, folks who are attending can open up and take a look at the devices and manipulate them as you like, pass them around. The Ellipta is considered the next generation discus. So it is a GlaxoSmithKline product developed in consultation with patient feedback and engineering and design. It offers the broadest product line among the new devices, and it straddles COPD and asthma indications with once daily dosing of a single inhalation. So you can see from the available products include a single entity inhaled corticosteroid, a single entity LAMA, combination LAMA-LABA, combination inhaled corticosteroid and LABA, and the newest arrival is the triple therapy ICS LABA-LAMA trilogy. So just some general background about this. Some of these products are available in hospital formats, either 7 or 14 doses per device, and some of them are only available in 30 dose format. So you might have an array of products on your shelves in the pharmacy. Just want to point out that the fluticasone in these devices is the furoate salt, which has a higher binding affinity for lung glucocorticoid receptors, and that's why you will see a lower dose than with the dipropionate. You would either get a 100 microgram or 200 microgram dose delivered per inhalation of the furoate. So it's not clear if there's a clinical advantage aside from the once daily administration compared to the dipropionate. There is evidence that the similar range of adverse effects that experienced with fluticasone dipropionate have been observed with the furoate. Just want to point out there are two strengths of Brio Ellipta. There's a 100 and a 200 fluticasone, and only the 100 strength is indicated in COPD. There's no added advantage for using the 200 and the potential risk of pneumonia and adverse reactions. So just small things like that. And I think there have been ISMP reports around the confusion of terminology where Ellipta may be considered, prescriptions may be written for Ellipta as a drug itself when it's actually the device. So one version of an Ellipta may be intended and another may be interpreted. So Ellipta is definitely the device, and you'll see that the Ellipta is stored in a plastic tray with a foil covering. Once the foil covering is removed, you should be writing on the inhaler the date that it was opened and the date that it should be discarded by, which is 6 weeks after removal if it hasn't been entirely emptied of its 30 doses. So it is one of the simpler devices available. The cap is slid open to expose the mouthpiece, and that causes an audible click, which provides a cue to the user that the dose has been readied. The user should breathe out away from the mouthpiece. Wrap the lips firmly around the mouthpiece, taking in a long, steady, deep breath. And you might see at the top of the inhaler there are some air vents. Those should not be blocked. So following the inhalation, if breath can be held for 5 or 10 seconds, the longer the better. Then closing the inhaler completes the transaction and readies the device for preparation for the following dose. So if it's an inhaled corticosteroid containing inhaler, the mouth should be rinsed after use. And so this is basically like open the device, inhale, and close. And that's the simplest format available. So there's minimal dexterity required. It does have an audio cue. It's got a dose counter. It's overall smaller in size than the discus, and the dose counter is larger, more easily seen, and it's designed to stand up. This device requires a minimum inspiration capacity of 30 liters per minute. And among the available inhalers, the typical range is between 25 and 60. So this is at the low end of the inspiration capacity required to get the drug in. Opening and closing the cover of the device without inhaling it will result in loss of a dose. And that lost dose will be held securely inside the inhaler, and you will not receive a double dose on the next inhalation. It'll be no longer available. Users might not be able to taste or feel the medication that they've inhaled. Same idea as the Turbuhalers. And the dose counter will show red when fewer than 10 doses remain in a 30-dose device. And after the last dose, the counter will show 0. And if it's opened again after that, the entire window will appear red. So that's the simplest of the new devices. Breezhaler is next on my list. It has a fewer range of options compared to the Ellipta. It has a LAMA and a LABA, and combination LABA-LAMA. There's no ICS format available for the Breezhalers. They're only indicated for COPD. These are also once daily dose products. It may take more than one inhalation to get the full dose delivered. Some of them are available in hospital format, and some of them are available in 30-dose format. So you could see different variations on shelves. So essentially, if you have a chance to take a look at your Breezhaler, if it's available to you, the cap has to be removed. The mouthpiece has to be tipped back to open it up. And then a capsule needs to be retrieved from the packaging and inserted into the inhaler. There are capsules hiding in the bottom of the box if you haven't been able to find them. They're a little tricky to find. So insert the capsule in the chamber and close it up till you hear a click. Once the capsule is in the device, hold the inhaler upright and press both buttons, the colored buttons at the base, one single time. So now the device is ready for inhalation. The user should breathe out fully away from the mouthpiece, then place the mouthpiece between the lips and breathing rapidly and steadily. They should hear a whirring sound and inhale through that. And again, holding the breath for up to 10 seconds if they're able. Once the first inhalation has taken place, you have to open it up and to visually inspect the capsule. Has it been emptied, or is there still white powder inside? If there's still white powder inside, close it up, breathe away, inhale. So the product monograph says most people can get the drug within 1 or 2 inhalations, but it probably depends on respiratory capacity. And for this one, the minimum inspiration capacity is 50 liters per minute. So it's ranging towards the top end of the ability to take a good deep breath. So some concerns with this inhaler, and I believe there was an ISMP report about the capsule being loaded directly into the mouthpiece and then inhaled and or aspirated instead of being loaded inside the device. So that is definitely a concern for cognitively impaired users. That should not happen. And another concern for this device is the piercing of the capsule is a single compression of those buttons. If you press it repeatedly, you might fracture the capsule, and then you'll have little bits of gelatin, which is not considered to be harmful to ingest. But if you get some of that in your lungs, your dyspnea and coughing is likely to worsen instead of improve. So this is technically a more challenging device to use. It has lots of setup steps, 6 of them. It requires fine motor skills and cognitive capacity to operate. It does have visual cues. You look at the capsule to see if the dose has been delivered, and it does have auditory cues in terms of the whirring sound to tell you that the drug is being delivered. So, Genuair, again, fewer versions available here. You have a single entity LAMA, which is aclidinium, and you have a LAMA-LABA, which is formoterol and aclidinium. So Tudorza and Duaclear. And these ones also have disposal or expiry considerations. The Duaclear should be discarded 60 days after it's removed from the bag, and Tudorza 90 days after removal from the bag if it hasn't entirely been consumed before then. This device has a dose counter, and it has a dose loading window which shows either red or green. So the steps would include removing the mouthpiece and pressing the colored button at the back 1 time and releasing it until you hear a click. And when you have done that properly and the dose is loaded, the window should appear green so you can see that you're good to go. The inhaler should remain upright. The user has to breathe out away from the inhaler. Place the mouthpiece between the lips and breathe rapidly and steadily. Again, holding the breath for up to 10 seconds. Once the inhalation has been made, you look at that window. Is it red or is it green? Um, So if it's red, you have delivered the dose in its entirety. If it's not, you have to repeat the inspiration. So this could take a few tries. And one of the safety features about this one is that it prevents the release of the dose until you have generated a sufficient inspiratory flow. So for this one, again, it's at the higher end of the inspiratory flow, 45 liters per minute. The Genuware with aclidinium and formoterol differs from the preceding ones in being a BID dosing inhaler. So I think we see a little bit less of this in Fredericton area, and it may be because of its BID application. It might be somewhat lower in cost than the others. It's a little bit trickier than the Ellipta. If a user accidentally loads a dose by pressing down and when they didn't intend to, then the monograph says you can keep the inhaler in the upright position, replace the mouthpiece cap, and leave it there until the next dose is due, and then do the inhalation. Now the fourth of the newest format inhalers is the Respimat. There are 4 approved versions of Respimat, one of which is not actually marketed. So the LABA, which is Striverdi or Oludaterol, is not available on the market yet. Combivent is available in Respimat format, but I think mostly what we see used locally in Fredericton would be the Spiriva Respimat. And these products straddle both COPD and asthma indications, and they are administered once daily. Something that's a little bit different about this is each individual dose requires 2 inhalations. So 2 inhalations once daily is how the long-acting versions of the Respimat are used. The Combivent Respimat, of course, would be used 4 and up to 6 times daily. It is available in a hospital format, the Spiriva and the Inspialto versions. And originally or initially, there were some concerns that the Respimat format of tiotropium might be associated with more safety signals than the Spiriva HandiHaler. But since those original concerns, a large trial has dispelled that observation. So some pointers about the Respimat: it requires assembly. So this adds an extra level of complication into the distribution process. So assembly of the medication and the cartridge requires a hard surface. This is one for which, if you have the sample available to assemble and load, it might be very helpful to get your hands on it and give it a whirl. The clear base has to be slid off the bottom, so there's a little safety mechanism that is slid downwards to allow you to pull the plastic base off. The medication cartridge needs to be inserted with the small end into the inhaler, and you really have to put that on a hard surface and lean on it pretty hard to snap it together. And then once the cartridge has snapped into the device, return the clear base back onto the inhaler, and it should not be disassembled by the user. Once it has been depleted, or 3 months after the first use, there's a locking mechanism that'll engage, which will prevent users from using it after its expiry date. So in order to use the Respimat, the manufacturer uses the acronym TOP, or TOP. So T is twist, O is open, P is push. So twist the base in the direction of the arrows until you hear a click, then open the mouthpiece, take your breath out, put the mouthpiece in your mouth and press. So that will generate a soft mist aerosol. And the delivery of aerosol from the Respimat is slower than from metered dose inhalers. It takes about 1.5 seconds. So that slows the deposition of drug in the back of the throat and mouth, and improves the deposition in the lungs. So then it's a 2 inhalation dose. You have to close it and then repeat the TOP. Twist, open, press, inhale. There's quite a little rigmarole to prime the inhaler at the first use. So the aerosol, the TOP function has to be performed at least 4 times before the device can be considered primed. And the Respimat is not, literally speaking, a metered dose inhaler, and it functions somewhat like a nebulizer in the way that it aerosolizes the medications. It has the portability of a metered dose inhaler, but some of the mechanics of a nebulizer, so it straddles those delivery dosage forms. So it's 12:35. There's a lot more to my presentation that we're not going to get to. I just want to highlight some key points. There is a table of different devices or different inspiratory capacities, different features of the devices. It's usually helpful to see them all at a glance, to familiarize yourself with how complex they are or how many steps are involved. Do they have cues? Do they have locking mechanisms? How much inspiratory flow do you need to use it? So that's a helpful table. I did want to mention the New Brunswick Drug Plan Special Authorization Revised Criteria. In the October 1st update circulated this year, I did a comparison, line-by-line comparison between the former criteria and the current criteria, and summarize the key differences for your benefit here. So one is that Trelegy Ellipta has been added as a special authorization benefit, so that's new. And the criteria that are being used are no longer tied to spirometry to define severity of disease. So spirometry at some point is required for the diagnosis of COPD, but not to quantify the severity of disease. So severity is evaluated on additional clinical measures such as the COPD assessment test, the number of exacerbations, and the number of hospitalizations. So if patients are being hospitalized on account of COPD exacerbation, they don't have to meet the predefined numbers that were specified in the past. You no longer have to demonstrate inadequate response to short-acting bronchodilators. It used to be a 2-month trial of short-acting bronchodilators at certain doses before you could consider getting approval of the long-acting bronchodilators. So that is a great change. There's a reduction in the duration of persistence of symptoms when you're adding a second long-acting bronchodilator. You used to have a 2-month period of persistent symptoms with symptoms, and now that is reduced to 1 month, so that's helpful. And something else that's new is inclusion of that group of people who have asthma and COPD overlapping, and that those would be candidates in which inhaled corticosteroid and combinations might be desired. So those are really important changes for patients getting access to drugs. But I guess the whole point of this presentation is that there always has been issues with device use and monitoring and re-education and retraining. And with the plethora of devices that are now available, it has only expanded. This is a little piece of good news here about the New Brunswick drug plan, which I hope will see benefit for our patients. And provincial drugs and therapeutics recognize that there are issues around ongoing access, not only to COPD inhalers, but to other medications and treatments, and that we need to embed processes in the delivery of care to make sure that patients can get access to the treatments that are optimal for them. We have to identify the gaps and address them comprehensively. And so at the highest level of D&T communication to medical advisory committees and nursing professional practice, the word is getting out that we can't just start people on drugs that they can't get coverage for on discharge. I'm not going to, I've included some slides for the old devices. They do continue to be widely used and or misused, and their features evolve. There's information in the PowerPoint presentation on those. These are the references that I used, and I just wanted to point out the Lung Association Saskatchewan has great resources, including videos for demonstrating how to use these devices, and they also have other resources to gather the information in one place. And once I get through the slides, I'll just show you. This is the COPD assessment test. It's graded on a 6-point scale, scoring range of 0 to 40 points. So it helps to assess patient health status across a continuation in daily activities. And it's a validated scale. And so some of the resources I wanted to show you include this color information graphic from ISMP, which gives you a description of the specific devices and their safety considerations. And that's available from ISMP. And what else did I show you? The other things I wanted to show you have fallen off my. This is the, if that table in the slides is difficult to read, this is the article which contains a table of comparative features. And it's from the CPJ 2016. And it's a very useful read. It's 12:42. That doesn't leave a whole lot of time for comments or questions, but I welcome any input. Are we still connected?
We're still here, Denise. No questions in St. John, and I'm guessing by the silence on the other end, no questions from the other sites. I just wanted to say thank you, though. Oh, one sec.
Ms. Corey, please go to X-ray.
Can I just ask a question to everyone? The Respimat, are the other sites loading and activating that Respimat if they get orders?
In Bathurst, we just put that into place recently.
I think in St. John at the regional, the respiratory therapists take care of loading all of the inhaler devices. Just wanted to say thank you very much, Denise, before the missing patient announcements started playing overhead. I really appreciate you speaking to everyone today. I found this presentation very useful, and it was great to have the hands-on devices to use. So, thanks again.
You're welcome. Have a great day.
Thanks.
You.
Bye-bye.
Bye.